about overgrowth syndromes, and I will especially focus on Beckwith Wiedemann syndrome, but I will also tell you about some rare other conditions that are characterized by overgrowth. So a few years ago, when I was asked to talk about overgrowth syndromes, the topic was quite short, even if there are a lot of things to tell about those rare conditions, but I was used to talking about Beckwith Wiedemann syndrome and some other syndromes that are quite close, that are called SIMPSON-GOLABI-BEHMEL or Sortos or reverse syndromes. But during the last years, the spectrum of overgrowth conditions became larger with the description of new syndromes. So I will give you a talk about these conditions and especially try to give you some clues or tools to distinguish between these conditions that can be quite difficult to distinguish between each other. So in my team, we are especially interested in studying the processes that control the growth and especially the fetal growth. So we are interested in the factors that control cell cycle. So you can think at two levels. The first scale is to think about cells, and the cell cycle will control cell proliferation and then the number of cells. But you can also think at a larger scale, and if you think at the scale of the whole body, the cell cycle will control the size and weight of the baby at birth. So that's the physiological processes, but if the cell cycle is disturbed, then it will lead to pathologies. And again, if you think at the cellular scale, disruption of the cell cycle can lead to tumors. But again, if you think at the scale of the whole body, disruption of the cell cycle can lead to overgrowth or growth retardation syndromes. And for example, I have been during the last years especially interested in studying this gene, which is called CDKN1C, which is a direct regulator of the cell cycle. And we identified mutations in this gene in overgrowth conditions, but also in growth retardation. For years, we knew that genetic somatic variations in oncogenes, anti-oncogenes, or in signaling pathways have been described in tumors when these variations occur at a somatic event. But more recently, the identification of germinal genetic variation in the same pathways have been implicated also in growth disorders. And for example, a few years ago, we identified variations in a specific oncogenic pathway, which is called HMGA2 PLAG1 IGF2 in patients with silver russell, meaning that the same processes that occur in tumors can occur as germinal events in overgrowth or growth retardation. Finally, we know that in tumors, epigenetic marks, microRNAs expression or non-coding RNAs expression are usually disturbed. But we also know that, for example, the Beckwith Wiedemann or the silver russell syndromes are usually caused by epigenetic defects. But what is interesting is that those epigenetic marks or non-coding RNAs are also regulated by several factors, and mutations in those factors that regulate epigenetic marks or non-coding RNAs have been implicated in different overgrowth syndromes, such as Sortos, Weaver, PERLMAN syndrome, etc. So what is overgrowth syndromes? So overgrowth is defined by any condition that is genetic or not that will lead to excessive growth. The overgrowth can be generalized and occur in the whole body, or it can also be segmental. And the overgrowth can be isolated, but it can also be syndromic, meaning that overgrowth will be associated with other clinical symptoms. The etiologies are multiple. It can be genetic or epigenetic, and I will focus on that during this webinar. But it can also be caused by metabolic defects. Sometimes it can be idiopathic, and especially in familial tall stature. And for patients with overgrowth, the etiology can stay unknown. So the first part of my talk will be about the Beckwith Wiedemann syndrome. So Beckwith Wiedemann syndrome is one of the imprinting disorders. So first I will introduce to you what is imprinting. So parental imprinting is defined by the differential expression of a gene depending on its parental origin. So for most of our genes, the expression will be biallelic, meaning that the paternal and the maternal allele will have the same level of expression. But for some of genes of our genomes, only one allele will be expressed. So we will define some genes that are called maternally imprinted, meaning that only the paternal allele will be expressed. And conversely, we can define some paternally imprinted genes, meaning that only the maternal allele will be expressed. In humans, the 11p15 region contains imprinted genes. So this region can be divided in two domains. The first domain is the telomeric domain, and in this domain, you can find the IGF-2 gene. IGF-2 is a strong promoter of fetal growth. In the normal condition, IGF-2 is only expressed from the paternal allele, and its expression is controlled by a structure that is called imprinting center region 1, or ICR1, which in the normal condition is methylated on the paternal allele only. The second domain is called the centromeric domain, and this domain contains the CDKN1C gene. CDKN1C is a strong negative regulator of cell cycle, so CDKN1C will reduce fetal growth. In the normal condition, CDKN1C is only expressed from the maternal allele, and its expression is controlled by another imprinting center region, which is called ICR2. And in the normal condition, ICR2 is only methylated on the maternal allele. So in the normal condition, you have a balance between the expression of one gene that promotes fetal growth, which is called IGF-2, and another gene which reduces fetal growth, that is CDKN1C. But if you have an unbalanced expression of one of these two genes, then this will lead to fetal growth pathology, which can be growth restriction, and in this case we will talk about Silver-Russell syndrome, but on the other hand it can lead to overgrowth, and in this case we will talk about Beckwith Wiedemann syndrome. So BWS has been described in the 1970s by two clinicians, Mr. Beckwith from the USA, who is a pathologist, and Mr. Wiedemann from Germany, who is a pediatrician. So this syndrome has been initially described as the EMG syndrome because of the association of exomphalus, macroglossia, and gigantism. But after that, some other clinical symptoms have been added in the description of this syndrome, which are organomegaly, ears anomalies, neonatal hypoglycemia because of an excess secretion of insulin, the facial nevus flammeus, and the lateralized overgrowth, which was called before hemihyperplasia. This overgrowth syndrome is associated with a high risk of embryonic tumors, and I will talk about this risk of tumors later in my presentation. So during the last decades, several scoring systems have been proposed to define what is BWS. So I won't go into details between all these different scoring systems, but those scoring systems were based on major symptoms that are mentioned in red on this slide, and what was called minor symptoms that are mentioned in black on this slide. So what is interesting is that you can apply those different scoring systems to cohorts that have been molecularly tested. So for each of these scoring systems, you can calculate the sensitivity, specificity of these different scoring systems. So that was a nice work from our colleagues from the UK who made this work on their cohort of molecularly tested BWS patients. So you can see that some of these scoring systems are highly specific but with a low sensitivity, meaning that you will miss a lot of patients because of this low sensitivity. And some other clinical symptoms are highly sensitive, meaning that you will miss only few patients, but in this case, the specificity is usually very low. So our colleagues in the UK proposed a new scoring system, but I won't go into details for the scoring system, because I will show you that very recently we proposed a new scoring system that we established during a consensus meeting. Because the question of a scoring system is which patient should be tested for 11p15 defects. Because nowadays we know that a lot of patients will present with incomplete presentations, meaning that they present some of the symptoms that have been described, but not all the symptoms. And we also know that for some patients, there will be only one symptom. For example, we know that for patients with isolated lateralized overgrowth, the prevalence of 11p15 defect is probably higher than what we knew before. So it is important to know that, because those patients with atypical clinical presentation, some of them will carry 11p15 defects, and it's important to detect those 11p15 defects in such patients because of the risk of tumor, and because of the fact that some patients will be screened for tumors depending on the molecular defect that is identified. There is another question that has to be assessed, is which tissue should be tested. So I will tell you the story of a little boy that we saw in our hospital in Paris. So the story starts with the diagnosis of a huge Wilms tumor at the age of 4 years and 6 months. And at the clinical examination, this patient was born with a large birth weight and birth length. He was quite tall, especially because of this target height was quite low. He presented also ears anomalies, and he presented also with an unnoticed lateralized overgrowth. So we suspected BWS for this patient, and we tested leukocytes for methylation at both ICR1 and ICR2, and we were quite surprised that the methylation at both ICR1 and ICR2 was normal. So at the time of surgery of the nephroblastoma, we asked the surgeon to take some fibroblasts and some tumoral and non-tumoral kidney, and we performed the molecular test on those tissues, and we were able to show a gain of methylation at ICR1 on both fibroblasts, non-tumoral and tumoral kidney, confirming the diagnosis of BWS in this patient. So what are the molecular mechanisms that have been identified in this syndrome? So I will go back to the 11p15 region. When a patient is suspected for BWS, we will test the methylation level at both ICR1 and ICR2. So we will define some categories of molecular anomalies. The first one is represented by 11p15 paternal isodisomy, meaning that for this region, you have a double contribution of the paternal allele and an absence of contribution of the maternal allele. So in this case, this will lead to a gain of expression of IGF-2 and a loss of expression of CDKN1C. And the combination of those two anomalies will lead to overgrowth. The second mechanism is not an epigenetic defect, but is represented by loss of function mutations of the maternal CDKN1C gene. So this molecular mechanism is quite rare because it's identified in about 8% of the BWS patients, but this mechanism is the most frequent in case of familial cases of BWS, because in this case there is a mutation of the gene, and this mutation can be transmitted to the children. The most frequent molecular defect is called ICR2 loss of methylation. So in this condition, you can lose the methylation at the maternal ICR2 here. And if you lose methylation at ICR2 on the maternal allele, then you will lose the expression of CDKN1C from the maternal allele. So you will lose the break of the fetal growth, and that will lead to overgrowth. And finally, the last mechanism is represented by ICR1 gain of methylation. So in this case, you can gain methylation here on ICR1 on the maternal allele, and in this case, you will gain expression of IGF-2 from the maternal allele, which will lead to the overgrowth phenotype. What is important to understand is that for most of the molecular defects, at the exclusion of CDKN1C mutations and the rare paternal duplications of the region, the molecular defect will occur in a mosaic state. So during the last decades, no consensus about how to diagnose and how to manage patients with BWS was available. So in 2017, we colleagues from Europe and some colleagues from the United States all came to Paris in order to establish consensus rules for the diagnosis and the management of BWS. So the conclusion of this consensus are available if you are interested by this subject, because they have been published in 2017 in Nature Reviews Endocrinology. So you can find the conclusion of the consensus in this paper. So I won't go through this more than 70 recommendations, but we'll focus on some of the conclusions. So the first one is about the clinical definition of BWS. So we proposed a new clinical scoring system defining some cardinal symptoms that are the most prevalent and the most specific symptoms. And they are represented by macroglossia, exomphalos, lateralized overgrowth, Wilms tumor if they are multifocal or bilateral, and hyperinsulinism that lasts more than 7 days. In all these symptoms, score 2 points. Aside these cardinal symptoms, we define some suggestive symptoms because those symptoms are less frequent or less specific. And for example, in this category, we put the birth weight over +2 SDS as only a suggestive symptoms and not a cardinal symptoms, meaning that some children with BWS will be born with normal birth parameters. So birth weight larger than +2 SDS is only a suggestive symptom. So we decided that if the scoring of the patient reach 4 points, it's enough to define a clinical diagnosis of BWS. But we decided that the indication for molecular test of 11p15 was possible as soon as the patient scored 2 points, including those patients with an isolated cardinal symptom. Because the aim of this decision was to be highly sensitive in order not to miss any patient because of the consequences of tumor screening. So we defined we introduced the definition of what is called now Beckwith Wiedemann spectrum. So we kept the definition of BW syndrome for those patients with a clinical score more of 4 points, meaning that it's the BWS now is kept for the patient with a classical clinical presentation. But we introduced the notion of Beckwith Wiedemann spectrum for those patients with incomplete presentation or patients with an isolated symptom, but who carry a molecular anomaly at 11p15. And the recommendations that we made during the consensus should be applied not only for the patient with BW syndrome, but also for all the patients with BW spectrum. So regarding the management, again, I won't go through all the recommendations that we done during the consensus, but I will focus on the strategy about tumor surveillance. So the tumor risk, the overall tumor risk in BWS is about 7%, but you can see on this slide that the tumor risk is highly correlated with the type of molecular defect. So we defined 2 groups with a high risk of tumor, which is represented by the patient with ICR1 gain of methylation and patient with 11p15 paternal unidisomy, because the risk of tumor is respectively 28 and 16%. And the risk is particularly elevated for Wilms tumor. So these 2 subgroups represent the high-risk group. We define 2 groups with an intermediate risk, which is represented by the patient with CDKN1C mutation and those patients with a clinical positive score but no molecular defect identified. So for these 2 groups, the risk of tumor is about 7%. And we defined a low-risk group represented by the patient with ICR2 loss of methylation, because the risk is between 2 and 3%, and especially in this subgroup, the risk of Wilms tumor is very low. So when we made recommendations for tumor screening, we took into account these specific risks depending on the type of molecular defect. So we recommended that abdominal ultrasound should be performed each 3 months until the age of 7 years for all patients, at the exclusion of the patient with ICR2 loss of methylation, because of the low risk of abdominal tumor in this specific subgroup. I will insist on the fact that the patient with a clinical score positive for BWS but without any molecular defect should be screened as the high-risk group. So the recommendations have been established in 2017. So is there something new? Actually, the new data haven't been really established during the last years. But I will talk about this paper from our colleagues from Italy and from the United States about the risk of hepatoblastoma in children with BWS. So they described they made a huge review of literature and included their own patients in this paper. And they look at the age of occurrence of hepatoblastoma in children with a confirmed diagnosis of BWS. So they established that in this specific condition, the risk of hepatoblastoma is especially high during the first 12 months of life, because 80% of the hepatoblastoma occurred before the age of 12 months. And they showed that all the hepatoblastoma in BWS occurred before the age of 30 months. So these two teams advocate for alpha-fetoprotein screening for hepatoblastoma until the age of 24 or 30 months in BWS. So raising the question of a revision of the consensus statement, because screening of alpha-fetoprotein for hepatoblastoma hasn't been included in the strategy for tumor screening. So to date, alpha-fetoprotein is not recommended, but probably we should discuss in the future to know if we should introduce alpha-fetoprotein for screening for hepatoblastoma. The only problem in this paper is that no molecular data are available from the patient included in this paper, and probably most of them must be patients with 11p15 paternal isodisomy. And it's important to notice that those patients already benefits from abdominal ultrasound, raising the question of the advantage of alpha-fetoprotein compared to abdominal ultrasound. So after Beckwith Wiedemann syndrome, I will talk to you about other overgrowth conditions. So I won't make a catalog of those syndromes because it would be not very interesting for you. So if you are interested in those rare conditions, we wrote 2 years ago a review that has been published also in Nature Reviews Endocrinology about those syndromes, and specifically describe the tumor risk that are associated with these conditions. So the problem with the other rare overgrowth conditions is that the prevalence is lower than BWS, meaning that there is only a limited number of reported cases or cohorts, and the molecular data are quite sparse. For most of these conditions, there is no international consensus, meaning that the recommendations for cancer surveillance, for example, are based on only experts' opinion, with various protocols between the different teams and the different countries. So SIMPSON-GOLABI-BEHMEL is probably the syndrome that is with the closest presentation compared to BWS. So I won't go through all the clinical symptoms, but you can see that the symptoms that are underlined on this slide are the symptoms that are in common between SGB and Beckwith Wiedemann syndromes. But you can also see that some symptoms are more specific, including supernumerary nipples, cardiac malformations, diaphragmatic hernia, or limb anomalies. SIMPSON-GOLABI-BEHMEL is only observed in males because SGB is caused by anomalies of the GPT3 genes, which is located on chromosome X. The tumor risk of SIMPSON-GOLABI-BEHMEL is about 8 to 10%, with tumors that overlap with the tumors that are described in Beckwith Wiedemann. In the French cohort that we described a few years ago, we described only 2 tumors in 34 patients. So the tumor risk is probably lower than the tumor risk that has been described in BWS. Nowadays, there is no consensus regarding tumor screening in SIMPSON-GOLABI-BEHMEL syndrome, and the recommendations that have been established are based only on the description of 26 patients. So it has been suggested for those patients that they should be screened with abdominal ultrasound on a protocol quite close to the protocol that has been proposed for BWS. And one author from Spain suggested also to add urinary catecholamines because of the description of neuroblastoma, and screening for alpha-fetoprotein or beta-HCG because of the risk of hepatoblastoma or gonadoblastoma. But again, I repeat, there is no consensus nowadays regarding tumor screening in this subpopulation. I will tell you now about 3 syndromes that are quite close between each other, which are called Sotos syndrome, Malan syndrome, and Weaver syndrome. So those syndromes are characterized by macrosomia, which is usually more important than described in BWS. The head circumference is usually very large, including at birth. And cognitive impairment has been usually described in those patients, but the cognitive impairment is variable, ranging from mild to severe. The tumor risk is probably quite low in these conditions with various types of tumor, meaning that leading to the recommendation of no systematic tumor screening for those patients because of the high variability in type of tumors. Sotos syndrome is classically associated with anomalies of the NSD1 gene, and the mutations are usually at the heterozygous state. The Malan syndrome is associated with anomalies of the NFIX gene. And finally, the Weaver syndrome has been associated with mutations, especially of those 2 genes that are called EZH2 and EED. So for Weaver syndrome, no systematic tumor screening has been recommended. I will finish with the PERLMAN syndrome because at birth, PERLMAN syndrome can mimic Beckwith Wiedemann syndrome because of fetal macrosomia, hyperinsulinism, nephromegaly. But those patients can be distinguished because of the precocious occurrence of renal failure and high mortality in the perinatal period. The risk of Wilms tumor is particularly high, and those patients should benefit from abdominal ultrasound scans like in BWS. PERLMAN syndrome is usually due to homozygous mutations or deletions of the DIS3L2 gene. So if you compare Beckwith Wiedemann, Simpson-Golabi, Sotos, Weaver, or Malan syndrome, you can see that there is a strong clinical overlap between those syndromes, meaning that it can sometimes be difficult to distinguish these syndromes between each other. There is also a molecular overlap between those syndromes. For example, a few years ago with our colleagues from Necker Hospital in Paris, we were able to demonstrate that for some patients with an initial diagnosis of BWS, but with no molecular defect at 11p15, some of them will carry NSD1 anomalies, which is associated with Sotos syndrome. And conversely, for some patients with an initial clinical diagnosis of Sotos syndrome, but with no NSD1 anomaly, we were able to show abnormal methylation at 11p15. And the same phenomenon has been described between BWS and SIMPSON-GOLABI-BEHMEL, as we in Trosso a few years ago were able to identify GPC3 mutations in male patients with a clinical initial diagnosis of BWS, but no methylation defect at 11p15. I will just tell you 2 or 3 slides about segmental overgrowth. And especially, I will talk about some new concepts about the PI3K AKT mTOR pathway. So this pathway is quite complex. This pathway has been implicated in physiological processes and especially the cell cycle and the cell proliferation, but also in metabolic pathways. And for years, this pathway has been implicated in tumors because tumors often present with mutation in this pathway, leading to an activation of the pathway and an excessive cell proliferation. But more recently, mutations in this pathway has been implicated in some segmental overgrowth conditions that have been called PROS, for PIK3CA related overgrowth syndrome, but also in Proteus syndrome or in Cowden syndrome. So I will first talk about anomalies of the PTEN that have been identified in Cowden syndrome. So Cowden syndrome, patients with Cowden syndrome present with very various clinical symptoms, including macrocephaly with autism, polyposis, or anomalies of the vessels and the skin, or lipomas. So this syndrome is caused by germinal mutations of PTEN, and the tumor risk in patients with Cowden syndrome is very, very high, meaning that those patients should benefit from tumor screening, especially for breast, kidney, thyroid, and endometrium. For other segmental overgrowth syndromes have been described more recently. They have been described for years, but the molecular mechanism has been identified quite recently. So, for example, for the Proteus syndrome, which is caused by anomalies of the skin and the vessels, Proteus syndrome is usually due to somatic mutations of the AKT1 gene. Some tumors have been described in patients with Proteus syndrome, but again, the type of tumor is very variable, and nowadays no screening strategy has been recommended for patients with Proteus syndrome. I will finish with the PIK3CA related overgrowth spectrum, which is called PROS. PROS is represented by several conditions and several acronyms that are mentioned here on this slide, depending on which tissue is affected. So PROS is due to somatic mutations of PIK3CA, and all these syndromes are in common, aside the segmental overgrowth, they have in common vascular or lymphatic anomalies, anomalies of the skin, and usually the head circumference is increased. The tumor risk is probably higher in this PROS condition because some cases of Wilms tumor, leukemia, or meningiomas have been reported. So the question about a systematic abdominal ultrasound scan has been raised for those patients. So I will finish with the diagnosis procedures in the case of overgrowth syndromes, because the question is how to distinguish between those different conditions. So the first question is, do the patient present with generalized overgrowth? So you have the syndromes that are described here, or segmental overgrowth. And the next question is that what are the associated symptoms aside of overgrowth, and especially looking at the head circumference. So is the head circumference normal or increased? And if there is a cognitive impairment, and if there is a cognitive impairment, what is the severity of cognitive impairment? Because usually patients with BWS have a normal cognitive development. SIMPSON-GOLABI-BEHMEL can present with normal cognitive development or only slight cognitive impairment, and the other syndromes are classically associated with a more severe cognitive impairment. It is important to have to know the strategy that will be performed in case of overgrowth syndromes, because if you think, for example, for the Sotos, Weaver, Malone, and SIMPSON-GOLABI-BEHMEL syndrome, then the first step will consist of sequencing. Nowadays, most of the molecular labs performed molecular sequencing based on next generation sequencing strategies, which are called panels of genes. And in these cases, we will be able to identify mutation in the different genes that I told you just before. If the clinical diagnosis initially is a Beckwith Wiedemann spectrum, then it is not necessary to perform sequencing, but you will need to test methylation studies at 11p15 to identify the gain or loss of methylation that are usually described in this disorder. And finally, if your patient presents with segmental overgrowth, then the NGS strategy, next generation sequencing strategy, should be performed on the affected tissue in order to find mutations in the affected tissues. If the first step molecular test is negative, then you can consider a second step molecular test, and this strategy has been described in our review in the Nature Reviews Endocrinology paper. So to conclude, I showed you that the processes that are implicated in the control of cell cycle are also implicated in the control of growth and in the occurrence and the development of tumors. Sorry for the typo. The overgrowth syndromes are usually associated with a higher risk of tumor, but which is highly variable depending on the condition. So that means that there is a need for an accurate molecular diagnosis, which can be based on next generation sequencing strategy, but also on methylation studies. And there is also a need for consensus about tumor screening and management of these patients with rare disorders. Finally, I will insist on the fact that you should consider the possibility of mosaicism in case of an initial normal result on leukocyte, and then consider molecular testing on an alternative tissue. And I thank you for your attention.
It's not my area of expertise, but I'm a little bit intrigued by this heme overgrowth phenomenon. So can that be explained somewhat molecularly why just one part or one half of the body is affected?
You mean for Beckwith Wiedemann, or
yes.
in general? Yes. For in Beckwith Wiedemann? Yeah. Yes. Actually, we say that it's probably due to the mosaic. We are used to say that it's because
we lost you.
Body size and yeah. So we usually say that. And for example, for the patient with no molecular defect in the leukocytes, when we ask for a skin biopsy, for example, we usually ask the clinicians to make the biopsy on the larger size of the body. But actually, it's only theory. And for example, I remember we had a case for whom the geneticist make a biopsy on the two sides, on the large size and on the smaller size, and we identified the molecular defect on the smaller size. So it's only theory. So, but yeah, probably it's because of the mosaic.
Thank you.
A lot of information. I'm interested whether you know of a series of patients with Wilms tumor who have been, how to say, investigated for genetic and syndromic reasons for the Wilms tumor. And the second question is, at your site, is it mandatory that a Wilms tumor patient is consulted with an endocrinologist or a geneticist?
Thank you for the question. So for the first question, you mean for isolated Wilms tumor, I think.
Yes, yes. Yeah. If nobody had thought about the syndrome.
Yeah, so there is one paper from the UK. In this paper, they tested patients who are called isolated Wilms tumor, and they found molecular defects in leukocytes in some of the, I don't remember the percentage exactly, but I think it was about 1%, but I don't remember the number. But they found some 11p15 defects in patients who are called isolated Wilms tumor. But actually, in this paper, there are not a lot of data about the phenotype of the patient. And for example, some patients in this paper are described with a large birth rate. So probably it's not really isolated Wilms tumor. And for some patients, it was familial Wilms tumor. So I'm not sure that those patients in this paper should be called isolated Wilms tumor, because probably they have some symptoms that make a diagnosis of BWS possible. So in my mind, and that's what we said during the consensus, an isolated Wilms tumor is not enough to indicate a molecular test. At the exclusion of the rare patient with bilateral Wilms tumor, the patient with multifocal Wilms tumor, or the patient with nephroblastoma. So
Okay.
that's for the first question. And the second question is, should the patient with Wilms tumor be
Consulted?
Yeah. That's quite difficult because Wilms tumor is not rare, so we will have to see a lot of patients. But I will go back to the clinical case that I presented during my presentation, because actually this child should have been diagnosed before the occurrence of Wilms tumor with BWS, because he was tall. The body asymmetry was not noticed before the diagnosis of Wilms tumor. So I think that the oncologist should be aware of the possibility of Beckwith Wiedemann syndrome. I know that in France, the pediatric oncologists are aware of the possibility of this diagnosis, and if the Wilms tumor is associated with one symptom that is not usual, they will address the patient to a geneticist. So I think that our work is to inform the oncologist of the possibility of this diagnosis, and in order that those patients might be addressed to a geneticist, at least if there is one specific symptom.
Thank you very much. I think it's a good topic for a collaborative study with the other networks, the oncology networks, because when you are not trained in the syndromes, the overgrowth syndromes, you may really miss some of the symptoms. And thank you. I'll look for the paper.
Yeah. It's really important. It's part of our work to disseminate the conclusion of this consensus, especially. So yeah, I agree with you about the importance of connecting the different networks between hemihypertrophy, genetic diagnosis of BWS, and developmental delay with hypomyelination.
Yeah.
It's not my experience for the French patient from the French cohorts about anomalies at MRI. I'm not aware of those kind of anomalies. Some patients have malformation of the central nervous system, but not this kind of anomaly. I'm not aware about that. Of course, we have some patients with a diagnosis of BWS and developmental delay, but we identified some risk factors of developmental delay in BWS, which are prematurity, because the delivery term of BWS patient is precocious, because in the French cohort, for example, the mean term of delivery is 37 weeks of amenorrhea instead of 41 weeks of amenorrhea. The second factor risk is the severe hypoglycemias during the prenatal period, the perinatal period, and the patient with severe hyperinsulinism and severe hypoglycemias are at risk of cognitive abnormal cognitive development. And the second risk for cognitive impairment is the rare patients with chromosomal anomalies. But in this case, the risk of cognitive retardation is due to the chromosomal anomaly, but not the BWS. Do you know of a large published series of? Okay, so we already answered to this question. For the patient with BWS, the recommendation for abdominal ultrasound is every 3 months until the age of 7. What about after that? So that's a good question. Thank you for the question. Actually, if we decided to stop the tumor surveillance at the age of 7, it is because at the age of 7, the risk of Wilms tumor in BWS patient is the same as those children with no BWS. Actually, the high risk period is between the age of 0 and 4 years. And between the age of 4 years and 7 years, the risk decreased. But between 4 and 7, the risk is still increased compared to the general population. So that's why we decided to continue the tumor screening between the age of 4 and 7. But at the age of 7, the risk of tumor is the same as the children in the general population. So that's why we decided to stop the surveillance at the age of 7. Actually, I'm really not an expert of this Proteus syndrome. I'm not sure that there is really treatment for that. I will just tell you about the management of the patient with PIK3CA related overgrowth syndromes, because I know that now that some medication have been developed, and especially in Necker Hospital in Paris, they developed a new treatment that inhibits the PIK3CA protein, I think, and that can be prescribed to the patient with PIK3CA related overgrowth syndrome with very good clinical results. But I'm not aware of this kind of treatment in the patient with Proteus syndrome. But sorry for not answering to the question, but I'm really not an expert of this rare condition. But I'm not aware of any treatment in these patients. Regarding tumor surveillance, there is actually no recommendations of tumor screening in patients with Proteus syndrome, because the tumors that have been described is very variable. So it's quite difficult to determine a strategy for the detection of these tumors. It was a great pleasure for me to talk about this very nice topic. Thank you very much to the audience for the questions that were very interesting, and for the discussion. And thank you very much again for the